All right, for the last part of this chapter, we're going to do electrocardiology, EKG, also known as ECG. Very first thing I want to say is don't get too bogged down on EKG for step one. You might see a little EKG, but I wouldn't spend tons of time related to EKG because they will not expect you to be a third-year resident in cardiology. But we will go through some of the basic aspects. All right, the first wave of the EKG, of course, is the P wave, which represents atrial depolarization. Next is the QRS complex, which represents ventricular depolarization. By definition, the first upward deflection after the P wave is the R wave. On EKG, we see this nice QRS complex, but oftentimes you don't see a Q wave, and in fact deep Q waves are suggestive of pathology, infarcts, or ischemia. So it wouldn't be uncommon or it wouldn't be unusual if you don't see this downward Q wave. This is ventricular depolarization. Next, we have an upward blip called ventricular repolarization. So I have atrial depolarization, ventricular depolarization, and ventricular repolarization. Well, where's atrial repolarization? I know you're sitting there going, well, it's buried in the QRS complex. I'm going to let you in on a little secret, but you have to be quiet. You can't tell other people because they don't realize this. But in reality, the EKG can't pick up atrial repolarization. Sure, it would be buried in the QRS complex, but in reality, the EKG doesn't pick it up. It's not a strong enough signal. All right, some important intervals here will be, number one, the start of the P wave to the start of the QRS complex. We refer to this as the PR interval. This is telling you about AV node delay. All right, PR interval, important aspects telling you about AV node delay. One of the things I want to point out, notice that the P wave is a rise, and then you come back, and it flattens out for a little bit before we hit the QRS complex. That'll be very important when we get to our last arrhythmia. Notice how it flattens back out. That's technically called the PR segment. Next is the QT interval. That's the start of the QRS complex to the end of the T wave. That is the QT interval. This denotes ventricular depolarization and repolarization. Remember, QRS is phase 0, T wave is phase 3. So the QT interval is telling us the entire duration of the action potential. We'll highlight that on the next slide. Next segment is the ST segment, which is right at the end of the S wave to the start of the T wave. For the ST segment, we're thinking about myocardial ischemia. Yeah, you got it. Whether it goes up or it goes down. ST segment elevation or ST segment depression. Right at the end of the S wave is the J point. Now I point out this. The J point becomes important because the J point is when all ventricular myocytes are completely depolarized. And it represents isoelectric point for the EKG. All right, so the J point is isoelectric. You'll find that J point to see if in fact the ST segment has elevated or depressed. Now, the height of these traces is influenced by three things. Number one, mass. Atrial depolarization, P wave. QRS complex, ventricular depolarization. Big difference in the size of these. Why? Because ventricular mass is much, much greater than atrial mass. Second is rate of change in membrane potential. Why is the T wave lower than the QRS complex? Obviously, it's not mass because both of these are dealing with the ventricle. What's different is the rate of change in potential. QRS is phase 0, the upstroke of the action potential. This rate of change in potential is much faster than phase 3, which is repolarization, T wave. And third, of course, is the orientation of the lead. Now, we won't go into any kind of details of that, okay, but we do know that we have 6 leads, okay, 3 limb leads, 3 augmented leads that look in the heart in a kind of a vertical direction, and then the precordial leads, which go around the heart and kind of slice the heart in a transverse section. We're not really going to spend any time on the precordials. So that's our basics of the EKG. As I indicated, what we would show on this slide is, notice that QT interval. Phase 0 generates the QRS. Phase 3 generates the T wave. So the QT interval is the entire duration of the cardiac action potential. So EKG is nothing more than a recording of the cardiac action potentials. And as I alluded to earlier, that's part of the reason that knowing cardiac action potentials is so important for step 1. Here's our standard EKG. Again, what would be the y-axis from heavy line to heavy line is 0.5 millivolts. Again, not all that huge yield. But heavy line to heavy line, with respect to the x-axis, we'll call that one big box. Heavy line to heavy line, one big box is 0.2 seconds. So 5 big boxes is a second, as illustrated at the top. You can see if you count heavy lines, 1, 2, 3, 4, 5, we go from 1 second to 2 seconds, and then same for 2 seconds to 3 seconds, etc. So that's our basics, and everything is standardized for the EKG. All right, the EKG is a voltmeter. All right, it is a voltmeter. It is measuring volts per unit time. The y-axis is volts. The x-axis is time. On the y-axis, one big box, which we'll look at, means heavy line to heavy line in the vertical direction, and the y-axis direction will be half a millivolt. I wouldn't get too bogged down on magnitude of voltage signals for step 1. I cannot speak for step 2 or step 3, but for step 1, I wouldn't worry about it too much. You should know, though, that the x-axis, one big box, which means heavy line to heavy line, is 0.2 seconds, which we'll look at on the next slide. All right, I'm going to give you a recommendation on how to approach EKG analysis for step 1. In reality, it's a good foundation for just working with EKG, period. EKG is a very clinical tool, but it gets very clinical very fast. And there are subtleties in it that certainly take a long time to learn, to be able to look for, to be able to appreciate, etc. And we don't need to get to that point for step 1. However, we do need a basis to work from. So here's my recommendation to try to approach EKGs for step 1. And again, it's a good basis all the way through. Very first step, rate and rhythm. Okay? If you look at the rhythm strip, they'll usually give you a rhythm strip down at the bottom. It's usually lead 2. So it'll run for several beats to see if there's a steady rhythm. All we're saying is, do the R waves appear regularly? In other words, is there a regular space in between the R waves? We can pick out the R waves because that's that big spike going up. So we're going to look and determine rate and rhythm. That's going to be our first step. We'll show you how to do very quick determination of heart rate in just a moment. Normal range for heart rate is 60 to 100. So if you got greater than 100, then you have tachycardia. If you have less than 60, you have bradycardia. Does this mean pathology? No, not necessarily. To find a very rapid heart rate, again, I'll show it to you pictorially on the next slide. We're going to find an R wave, preferably one that hits a dark vertical line. Okay? Preferably one that hits a dark vertical line. And then we're going to have a pattern of numbers that we're going to go through, moving to the right from that vertical line. If the subsequent R wave occurs in the second heavy line from the first one, then we know the heart rate's 150. It occurs on the third heavy line from the first R, then the heart rate is 100. And again, I'm going to illustrate this on the next slide. And you're going to have an actual pattern, a number pattern that you need to remember. After we look at rhythm and rate, just kind of qualitatively look at it. Do you see P, QRST, P, QRST? Do they look somewhat normal? They're not going to be perfect like a textbook. Do you see a little blip that looks like a P wave and then a QRS? Okay, it looks like a QRS. And following that, we see another blip. That's the T wave. Okay, P, QRST, P, QRST. Do they occur? Do you see them? Are they okay? And are they in the right order? P, QRST, P, QRST. Step 3, you should jump immediately to the PR interval. You'll see why that is as we go through some arrhythmias. I mean, just jump right to it. Is it consistent? And is it a normal duration? All right, the RR interval should be between 120 and 200 milliseconds. Now, an easier way to remember that is just say 35. Someone says PR interval, you say 35. 35, 35, 35, 35. 35 means 3 to 5 boxes. Little boxes. This means the little lines in between the heavier lines. So we're looking for 3 to 5 small boxes for a normal PR interval. So that's the third step. Just jump to that PR interval. All right. Observe several cycles to make sure that they're consistent. All right, so here's our heart. And what we're going to do is we're going to bisect it vertically and bisect it horizontally. So we're going to use the two leads that do that. The two leads that bisect the heart vertically and horizontally are highlighted on your slide for you. These are lead 1 and AVF. All right, lead 1 and AVF. Again, picture this as sitting on someone's chest. First thing you should remember is lead 1 will be 0. We're going to do a horizontal axis. We're going to make the left arm of the person. That's the positive end of lead 1. That's the left arm. That's 0. We're going to bisect it horizontally so the right arm becomes 180 degrees. So we're effectively cutting the heart right in half, okay, in a horizontal manner, which of course if we just cut it in a horizontal would create two pieces of a pie, a top half and a bottom half. Now what we're going to do is create the other two pieces of the pie. We're going to take AVF, which is positive, the lead is positive at the foot, and we're going to call that 90 degrees. So we're going to bisect the heart vertically. So at the bottom, which will be the positive end for AVF, we're going to call that plus 90. And then as we go up through the head, will be minus 90. So again, we're vertically bisecting the heart. Notice how that creates 4 pieces or 4 quadrants. It's like taking a pie, slicing it horizontally, slicing it vertically. You get 4 pieces of the pie. The normal axis is minus 30 to 110. All right, minus 30 to 110. That's what's illustrated on the slide. But really, all that matters is can you determine the mean electrical axis, what quadrant is it in? And we can do that by just looking at lead 1 and AVF. Again, this is ventricular depolarization. So we're looking at the QRS complex. All right, left arm, lead 1 is 0 degrees. AVF, the foot, is 90 degrees. So we're making a little grid here. 0 to 90, that's our normal range. I know this isn't how you were taught in math, but this is how we do it for EKG. Now, if I move to the left, think about the left arm raising up all the way to the vertical position. That will be minus 90 degrees. So if my left part gets raised up, I have a left axis deviation. Now my right arm is the negative end of lead 1. So in other words, in our little grid here, it's plus minus 180. So if I'm to the right side, if I'm in the part of the pie that's on the right side, then I'm going to have a right axis deviation. So we got a left axis deviation, means my left arm goes up. If I'm on the right side of the pie, right arm, then I have a right axis deviation. Again, all we have to do is get into the correct quadrant. The fourth thing that we need to do for EKG is determine the mean electrical axis. The mean electrical axis is the net direction of current flow during ventricular depolarization. All right, depolarization, the net direction. Call it a vector of current flow. Ventricular depolarization. Now I keep emphasizing depolarization because what that means is we're looking at the QRS complex. All right, the QRS complex. Now each lead is represented by an angle. What we're going to do is we're going to simplify this down to what's called the quadrant method. For step 1, all you have to know is the mean electrical axis in the appropriate quadrant. So we're going to take the heart and take it like a pie, okay, and split it into 4 equal sections. And every time you're doing this, when you're thinking about mean electrical axis, envision the picture of the heart and the axes that we're going to talk about, all right, that it's plastered on someone's chest, okay? And that's how we'll look at it here as well. All right, this shows our 4 pieces of the pie. If you notice in the upper left, all right, we have our 4 pieces of the pie. We bisected it vertically with AVF. We bisected it horizontally with lead 1. And the left arm of lead 1 is positive, and the foot portion of AVF, the downward part, is positive. So if we're in that little left area there, which would be 0 to 90 degrees, then it's normal. If my left arm's going up, if I go up on the left, then I got a left axis deviation. If I move toward the right side, then I get a right axis deviation. And we're really not going to discriminate between extreme right axis deviation and right axis deviation. That won't be important to differentiate. All right, now here's the key. We're bypassing a lot of physics, but here's the key. If the net voltage, all right, now let me back up. Net QRS voltage, what does that mean? That means you find the J point, that's isoelectric, and you look at the QRS complex, and you determine the net voltage. The net means I look at how high it goes, and I subtract by the downward deflection. So the magnitude of the upward versus the magnitude of the downward. If the magnitude of the upward is greater than the magnitude of the down, then we say it's positive. If the down part is greater than the up part, then it's a negative. Then it's a negative lead. So again, QRS complex, find the J point, that's isoelectric 0. You look at the QRS complex. If the up part of QRS is greater than the down part, then it's positive. If the downward deflection is greater than the upward deflection, then it's negative. If both lead 1 and AVF are positive, then that means the mean electrical axis is between 0 and 90 degrees, plus 90. And remember, plus 90 on our little scale here is at the foot, the positive end of AVF. So if lead 1, AVF are both positive, then we know immediately that we have a normal mean axis. Very quick, very quick. Now, if I have a positive lead 1, which means I'm working with my left arm, but AVF is negative, then that's like raising my left arm. Because what that means is The mean electrical axis is between 0 and minus 90. So if lead 1's positive and AVF is negative, all right, if lead 1 is positive and AVF is negative, then you have a left axis deviation. What causes a left axis deviation? One of the big ones to look for, the big two to look for on step 1, will be left ventricular hypertrophy or left ventricular dilation. Now, we can also get a left axis deviation if we get conduction problems on the left bundle branches. The exception is the posterior bundle branch. All right? So all the other bundle branch blocks or conduction problems to the bundle branches will cause a left axis deviation, all the ones on the left side, except for the posterior bundle branch. You will also see a left axis deviation with an acute right side MI. So if I get an MI on the right side, I'll get a left axis deviation unless the right ventricle dilates. So again, left ventricular dilation, hypertrophy, those are going to be the main ones. But bundle branch block on the left side, except the posterior bundle branch, will cause left axis, and acute right side MI unless the right ventricle dilates. All right, now, if lead 1 is negative, now the picture here shows a negative lead 1 and a positive AVF, but it really doesn't matter what AVF is. If lead 1 is negative, I'm no longer on my left arm, I'm now doing my right arm. I'm doing my right arm. And so if lead 1 is negative, then you know you have a right axis deviation. What causes the right axis deviation? Well, the opposite things that cause the left. Right axis deviation will be right ventricular dilation or hypertrophy, right ventricular bundle branch or right ventricular conduction pathway blocks, and left posterior bundle branch, because remember we made that qualification previously, and an acute left side MI. Just like an acute right side MI caused a left axis deviation, an acute left side will cause a right axis deviation, unless, of course, the left ventricle dilates. All right, so this is the quadrant method, very basic aspect. Can you get it to the right quadrant? That's all that's expected. Very simplified approach. All right, let's talk about typical arrhythmias you're likely to see for step 1. We'll start first with the heart blocks. First degree heart block. By definition, first degree heart block is a long PR interval. It's telling me I'm having a slow conduction, an abnormally slow conduction through the AV node. All right, let's go through our steps. Rate, rhythm. Rate, rhythm. Do you see a steady rhythm? Hopefully you say yes. That's pretty darn steady rhythm. Then I determine the rate. I'm going to pick here as 300, 150, 100, 75, 60. All right, so heart rate is between 60 and 75, so heart rate is normal. So I have a steady rhythm and a normal rate. Now I'm just qualitatively looking. I see P, QRST, P, QRST, P, QRST. Yeah, and they look okay. They look okay. Now what I do is I go, all right, let's jump to that PR interval. And I look at that PR interval, and hopefully you can see this jumps right out at you. Okay, 35 should be 3 to 5 small boxes. 3 to 5 small boxes. Well, there's the start of the P wave. Okay, there's the start of the QRS. So my PR interval is significantly longer than one big box. Okay, I'm looking for longer than one big box. And this is significantly longer than one big box. This is first degree heart block. All right, here is second degree heart block Mobitz type 2. All right, so we look. Do we see a steady rhythm? Well, we have an unsteady rhythm. Well, could be Winky block, could be Mobitz type 2. All right, the P waves are labeled for us. The next step is just qualitatively look for them. P, QRST. Yeah, I see P, QRST. And they look about right. Now what I'm doing is I jump to that PR interval. Looks pretty consistent. First one, second one, third one, fourth one. Aha! P wave, no QRS. Then the fifth one, that PR interval is not, identical, but it's darn close. It's darn close. Notice the consistency of the PR interval. But we have a P wave with no QRS. This is Mobitz 2. Okay, this is Mobitz 2. Contrast that again with Winky-Bach, in which that PR interval is getting progressively longer. Hopefully you can see in this that PR interval going across is not getting longer and longer. It's pretty consistent there. And then we get a P wave with no QRS. And again, Mobitz 2 could be steady, could be unsteady. So I have an unsteady rhythm. I'm thinking Winky-Bach, Mobitz 2. I see PQRST, PQRST. Now I'm looking at that PR interval. Yep. Oh, there's P wave, no QRS. And then, yep. Okay, pretty tight PR interval. Mobitz type 2. All right, next is second degree heart block. Second degree heart block, every QRS complex is preceded by a P wave, but not every P wave is followed by a QRS. All right, that is the definition. So hone in on the definition. Every QRS complex is preceded by a P wave, but not every P wave is followed by a QRS. Which means some of the impulses are not getting through the AV node. We're going to have two types of second degree heart block. We're going to have Mobitz type 1, also known as Winky-Bach, in which we'll have a progressive prolongation of the PR interval until a beat is missed, and then that cycle will begin again. The next slide will illustrate Winky-Bach. This is going to have an unsteady rhythm. Remember, the first thing we do, rate and rhythm. So if you see an unsteady rhythm, one of the things that's going to jump in on your differential, one of the aspects that should jump in on your differential is Winky-Bach. It may or may not be Winky-Bach, but we know if we have an unsteady rhythm, could be Winky-Bach. Second type of second degree heart block is Mobitz type 2. Here the PR interval will be consistent and won't change in length. That's how we diagnose between Winky-Bach and Mobitz type 2. Winky-Bach will have a varying, more specifically an elongating PR interval until we miss a QRS complex, and then it'll start back over again. Whereas in second degree heart block, we're going to have no QRS following a P wave. But whenever we have a PR interval, it'd be pretty much the same. Now, the rhythm can be steady or unsteady in Mobitz type 2. It will depend upon the block ratio. A lot of times these have specific block ratios, like a 2-to-1 block or 3-to-1 block or a 3-to-2 block. So it will depend. So for unsteady rhythm, could be Winky-Bach, could be Mobitz type 2. All right, this is an example of complete heart block, and we have complete dissociation between atria and ventricle. This is oftentimes very difficult to diagnose, but hopefully, if you will utilize my little basic technique here, you'll be able to pick this up without a problem, all right? Because there are going to be a couple of real telltale signs that scream to us complete heart block. First thing we do, steady rhythm. Do you see a steady rhythm? Hopefully you say yes. I see a pretty steady rhythm. So what are we going to do next? Determine heart rate. All right. 300, 150, 100, 75, 60, 50. Dang, that's slow. Look how slow that heart rate is. All right? 300, 150, 100, 75, 60. It's less than 50. It's less than 50. So if you see a nice steady rhythm, then you're determining the rate, and you go, dang, that's slow. Put in your mind immediately, complete heart block. All right, put in your mind immediately, complete heart block. So I have a steady rhythm. Dang, that rate is slow. Complete heart. I'm thinking, maybe complete heart block. So now what do I look for? PQRST, PQRST. Let's go start on the far left. We got a little blip there. I don't know. Is that a P wave? Maybe it's a T. I don't know. There's a QRS. That's clearly a Q. There you go. Second QRS has a P. Looks like a PR interval. But the third? I don't know. That, I don't see the same thing that I saw on the second one. And now the fourth one. Yeah, that looks like a P, but look how long before it occurred. And then I don't know that I'm seeing a P. I don't know. Where are my P waves? Where are my P? Now, you're done. You're done. Steady rhythm. Dang, that's slow. I'm not seeing the very tight PR interval. Answer, complete heart block. I'm going to draw in here most of the P waves. I didn't put in the very last one, but those are the P waves. Now here's the thing about EKG. To get this answer right, unless you're going into cardiology or, we got to get more detailed for the clinics. But for step one, we're just trying to diagnose and move on. It is not important for you to find all the P waves. You don't have to sit here on this trace finding every single P wave. We see steady rhythm. Dang, that's slow. I look at the very first QRS complex. Okay, maybe that's, I don't know. Okay, the second one, that looks like PR. Third, no, there's no real PR there. Fourth, okay, maybe there's a PR, but look how long that PR is. Fifth, I don't see a PR. In reality, the P wave is starting right with the QRS complex. Okay, we don't have to find every P wave. We diagnose. We diagnose. Steady rhythm. Dang, that's slow. I do not see a nice tight PR interval. Answer, third degree heart block. All right, third degree heart block. Steady rhythm, very slow. Won't be able to find a tight PR interval all the way across. You don't treat one. On this example, we have 5 QRS complexes. One of the 5 looks like it has a normal PR interval. Only one of the 5. Then it's not there. We have an atrial rate. That's the P wave. We have a QRS rate. That's the ventricular rate. Okay? Atrial ventricular rates they're not talking to each other. The only electrical connection between the atria and the ventricle is the AV node. We're not getting conduction to the AV node. That's what complete heart block means, or third degree heart block. All right, so nail this one if you get it on step 1. Next, this is an example of what we call atrial flutter. Now, atrial flutter is a very fast atrial rate, above 280 beats per minute. But we still have normal coordinated conduction. It's just we're going really, really fast. So we have atrial conduction and coordination that's intact. All right, now, what are we doing? Rate, rhythm, rate, rhythm. We do have a regular rate. Excuse me, a steady rhythm, right? We have a steady rhythm. Then we go through 300, 150, 100, 75, 60. All right, so the heart rate's about 60, right? 300, 150, 100, 75, 60. It's pretty close to 60. So I have a normal rate, steady rhythm. Now what am I looking for? P, QRST. And I start looking, I go, what? What? Look at that. I don't know what that is. I know what the QRS complex is, but I don't know what's going on in between QRS complexes. But it's a pretty similar wave all the way through. That's a key point. Notice that wave that's occurring in there, that's called a sawtooth appearance. That wave is pretty consistent between the QRS complexes. In other words, it looks pretty similar. That's why we call it a sawtooth. Diagnosis, atrial flutter. So, steady rhythm, rate's okay, but I can't find P and T. P and T, I don't know what that. I see a definitive, definite wave. There's no question there's a wave there. But I don't know if it's P or T because the pattern is too much. That's the sawtooth. Diagnosis, atrial flutter. All right, contrast this with atrial fib. This is atrial fibrillation. Now, when the heart is fibrillating, when the atria are fibrillating, we have absolutely no coordinated conduction. So it won't generate a normal looking wave on the EKG. You get the same thing with ventricular fibrillation. We don't have an example of it, but if you can't make anything out, there's no steady wave, then it's VFib, which of course is incredibly dangerous. You have to shock them to get them out of it. This is atrial fibrillation, completely uncoordinated electrical activity. So there is no real contraction, at least unison contraction. It's no longer functioning as a syncytial. So we're not going to be able to pick up the P wave. So first thing I look at, do you see a steady rhythm? Nope, not a steady rhythm. So we're thinking in our head, okay, Winky Bach, Mobitz type 2. Third one to put in your head, AFib. All right, third one to put in your head, AFib. So unsteady rhythm, Winky Bach, Mobitz type 2, AFib. So what do we go to next after we get that unsteady rhythm? I'm not even going to mess with heart rate. I'm going to say, all right, do I see P, QRST, P, QRS? All right, I see QRS complex, very first one. I don't see really anything before that. Now I've got another QRS complex, and it looks like, what are those 2 P waves? Now I have another QRS complex. What is this, 3 P waves? Another QRS complex. Maybe there's 2 P waves. What the heck? Is that even a P wave? So if you have an unsteady rhythm, can't find a visible P wave, AFib. Bingo. Next one, AFib. Unsteady rhythm, can't find a P wave, AFib. All right, the last arrhythmia is called Wolff-Parkinson-White syndrome, WPW syndrome. In this scenario, we have an electrical pathway in addition to the AV node. It's basically we are bypassing the AV node. So we have an electrical pathway running between the atria and the ventricles. This is known as the bundle of Kent. As you might predict, since we're bypassing the AV node's job is to slow that conduction, then we're going to have a short PR interval. All right, same with the others. Do you see a steady rhythm? Yes, we have a nice steady rhythm. Now let's determine rate. Do it with me. I'm not going to draw on the arrows, but do it with me. 300, 150, 100, 75, 60. Well, actually, it's kind of slow. It's not quite dang that slow, but it's slow. This is actually 50. So they're a little bradycardic. That's not typical for a WPW, okay? But it could occur. All right, it could occur. So we have a steady rhythm, kind of a slow rate, but it's not dang slow. But anyway, it's slow, so putting in my head third degree heart block. Now I'm looking for P, QRST. Oh, this is not third degree heart block. Look at that. P, QRST, P, QRST, P, QRST, P, QRST. You know, that PR interval looks pretty darn good, so it's not dang slow. That just eliminated third degree heart block. Now, what do we have? What do we see? Something's a little bit off. Notice how quickly the pen starts to go up after the P wave. Right here, this is indicated, this is what we call a delta wave. So it looks like a very widened QRS because what we're seeing is depolarization in that ventricle area early. So notice the sharp rise of the R wave, but notice the slow rise, and then bam, the R wave goes up. So again, a slow rise, and then bam, the R wave goes up. So we don't have that nice flat PR segment that we discussed, that idea of the PR segment. So no flat or isoelectric PR segment. This is a delta wave, this is WPW. Typically have a very short PR interval. All right, that's WPW. Really worried about reentrant tachycardias with this, because if that atria starts going real fast, bam, it'll make that ventricle go real fast. And again, you could also get a reentry tachycardia. WPW, bundle of Kent. All right, some important things that can affect the EKG. And these are more for, look for these in clinical vignettes, all right, in the write-ups of clinical vignettes, more so than you being able to have to detect them on the EKG. You might have to, but probably not as likely as they're going to say in a clinical vignette. All right, in clinical vignette, patient X shows an elevated ST segment. Well, if you have an elevated ST segment, think transmural infarct or Prinzmetal angina. All right, transmural infarct means transmural across the wall. Please remember that term, transmural, across the wall. We're going to apply that word in respiratory later. And Prinzmetal is that unstable angina, okay, thought to be due to coronary vasospasms. If the ST segment is depressed, you can put it on antidepressants and, make, too corny, wasn't it? Okay, sorry. If the ST segment is depressed, then think subendocardial ischemia or the classic or stable angina, also known as exertional angina, associated with a stress test. This is thought to be due to blockage of the coronary arteries. All right, with respect to potassium, hyperkalemia, as you can see on the slide, hyperkalemia increases the rate of repolarization. So hyperkalemia is going to result in an increased rate of repolarization. Now, let's stop and think about that. That's going to cause sharp spiked T waves, because remember, the T wave is repolarization, and the height of the change on the EKG is influenced by the rate of change in potential. So if we increase the rate of repolarization, the T waves will get greater. In other words, the magnitude will be higher. So characteristic change on the EKG, hyperkalemia will be sharp spiked T waves. And since we're increasing the rate of repolarization, it's also going to shorten the QT interval. As you might predict, hypokalemia is going to do the opposite. It will decrease the rate of repolarization, and so we may get late repolarization waves that we call U waves. Remember, U waves would be a next wave following the T wave. So T is normal for ventricular repolarization, but if we get some delay in the repolarization process in some parts of the myocardium, then we can see U waves on the EKG. This, of course, will prolong the QT interval. And don't forget that very important arrhythmia associated with prolonged QT interval, that's torsades. Now, the mechanism by which potassium does this is not well defined, so you will not be asked about the mechanism on this. It's still debated. We don't know the exact mechanism. We cannot apply concentration gradients, etc., that relate to these that we did for nerves. So please don't try to do that. Mechanism unknown. But these are characteristic changes that we're going to look for. Most likely, it's going to be written in the clinical vignette rather than you having to detect it off the EKG, at least for step 1. So again, clinical vignette may say patient shows sharp spiked T waves on their EKG. You're immediately thinking hyperkalemia. Or if they say U waves in a clinical vignette, immediately thinking hypokalemia. Okay, on this slide we indicate calcium. Notice that hypercalcemia decreases the QT interval. Hypocalcemia increases the QT interval. If you have the 2014 edition of the book, which is very unlikely, but if you do, we have it backwards in that book, so please correct the book. We corrected it for 2015. Again, hypercalcemia, too much calcium decreases QT interval. Too little calcium increases the QT interval. Once again, this is the heart, not nerves. This is the heart, not nerves. And just as we described for the potassium earlier, this almost assuredly involves the voltage-gated potassium channels that cause repolarization. So, too much potassium or too much calcium makes those channels open sooner. And you decrease QT interval because you're repolarizing faster. Too little calcium, too little potassium makes those channels delay. They don't open as quickly. And so the QT interval goes up because I'm delaying repolarization. Mechanistically, how that works, we don't know, but that's, very likely the mechanism, okay, is involving the potassium channels. But how calcium, how potassium does that, we don't know. We don't know. But that's the way to remember it. All right? Too much, they open faster. Too little, they don't open as fast. And then you should be able to figure things out from there. All right, that finishes off EKG and electrical activity of the heart.